So today we are going to study about thyroid hormones and anti-thyroid drugs. So the thyroid hormones, they are of three types: thyroxine, triiodothyronine and calcitonin. Thyroxine and triiodothyronine are synthesized by thyroid gland, and calcitonin, it is secreted by parafollicular cells. Parafollicular cells. So now we will see synthesis, storage and secretion of the thyroid hormone. How is thyroid hormone synthesized? It is synthesized and stored in thyroid follicles. So for the synthesis of thyroid hormone, the main component is iodine, which is obtained from our diet. How is it synthesized? The plasma iodine, which is the iodine which is present in the plasma, is taken up by the thyroid follicles by sodium iodide symporter. So now the plasma iodine is inside the thyroid follicle because of sodium iodide symporter. Now the second step is oxidation. Now the iodide is oxidized into iodinium by thyroperoxidase with the help of hydrogen peroxide. Now this iodinium combines with tyrosine, which is residues of thyroglobulin. Now this iodinium is combined with tyrosine and which undergoes iodination. Now this iodination results in the formation of monoiodide tyrosine and diiodotyrosine. This monoiodotyrosine and diiodotyrosine further undergo coupling reaction. This coupling reaction results in the formation of T3 and T4 hormones. T3 is a combination of monoiodotyrosine and diiodotyrosine, whereas T4 is a combination of diiodotyrosine and diiodotyrosine. Now this is stored in a thyroid gland containing iodinated tyrosine, and it is released in the form into this blood circulation. Now we will see regulation of thyroid hormone. The secretion of thyroid hormone is regulated by thyroid stimulating hormone and thyroid releasing hormone. Thyroid stimulating hormone is released by anterior pituitary gland or adenohypophysis, and thyroid releasing hormone by hypothalamus. So normally the daily secretion of thyroxine or T4 is 70 to 90 micrograms, and the triiodothyronine is 15 to 30 microgram. In the peripheral tissue, the T4 gets converted into T3, and this T3, it is an active hormone. Now T3 and T4, they are bound to plasma protein. If these T3 and T4 are not bound to plasma protein and they are a free hormone, it is transported into liver and it is metabolized and excreted in the bile. So now if we look on to half-life of each hormones. So T4's half-life is about 6 to 7 days, whereas T3 is about only 1 to 2 days. But then the T3 is 3 to 5 times more potent than T4. Now we will see the action. The action of T4 and T3 is essential for normal growth, development, function and maintenance of all the body tissues. The most important metabolic functions of T3 and T4 are it increases metabolic rate, enhances carbohydrate and protein metabolism and stimulates lipolysis. If there is a congenital deficiency in thyroxine or thyroid hormone, it will lead to cretinism. This thyroid hormone, it also stimulates erythropoiesis, and it is also essential for normal functioning of CNS, skeletal muscle, cardiovascular system and GIT. Suppose we have hypothyroidism, a person or the patient will suffer from constipation, whereas if the patient has hyperthyroidism, the patient will suffer from diarrhea. Now we will move on to mechanism of action. Now this thyroid hormone, it acts as a specific receptor, and this thyroid receptor are nuclear receptors, and it is also a steroid receptor. So now this TH, which is a thyroid hormone, or we can take it as T3. This is a cell, and this is a T3 hormone. Now this T3 enters the cell, and now once it enters the cell, there is a receptor. So now this T3 binds to the receptor, and in the cell it forms a T3. Now this is a T3 receptor complex, and now this T3 receptor complex, it moves into the nucleus. Now we will look in through the nucleus. Now in this nucleus we have a DNA, and this is a T3 receptor complex. Now this T3 receptor complex, it binds into the DNA, and now this now this is bound to the DNA, and now it activates gene transcription. Now this leads to protein synthesis. And now we will talk about uses of thyroid hormone. Both T3 and T4 are the drugs present in the body, whereas levothyroxine is a synthetic T4 and liothyronine is a synthetic T3. Now these two synthetic drugs can be given orally. So now where are these drugs used? It is used in replacement therapy. We spoke about cretinism, which is called deficiency of iodine or thyroxine hormone. So if there are two types of cretinism, which is sporadic and endemic cretinism. Sporadic is caused by congenital absence of thyroid hormone synthesis, and endemic cretinism is caused by extreme deficiency of thyroid hormone. And this early detection of endemic cretinism can be treated immediately, and this should be treated immediately to avoid mental retardation in the patient. Now to treat this patient, a patient should be given with levothyroxine 10 to 15 microgram per kg per day, which is orally, and it is started and monitored, and this replacement should be considered lifelong. Now the second condition where we use the replacement therapy is hypothyroidism. In adults, there is a result of decreased thyroid activity, and this can be reversed by appropriate treatment. That treatment is given by levothyroxine 50 microgram daily, and it is increased gradually by 2 to 3 weeks, and this increase depends on plasma TSH levels. And now the third condition is myxoedema coma. This myxoedema coma is a medical emergency. Now when there is a myxoedema coma, intravenously thyroxine 500 microgram or liothyronine 100 microgram is given, and this should be given with the prophylactic corticosteroids, and this is given so that there is to avoid adrenal insufficiency.